Welcome to this week's podcast by Step Kids Nutrition, where we explore matters related to pediatric nutrition with an invited guest. My name is Professor Roseanne Meyer. I'm a specialist pediatric dietitian with almost 30 years of experience in pediatric nutrition. In each podcast episode, we will dive into the science and also practical tips behind topics related to childhood nutrition with an invited specialist. Whether you're a healthcare professional, a parent, or just interested in pediatric nutrition, you're at the right place. I'm absolutely delighted this week on Step by Step Kids Nutrition podcast to have a friend and a dear colleague, Professor Adam Fox. I've known Adam for many years, but I'm going to read out your biography because there's so much.
And you've known me for like 30 years, I reckon. The best part of it. Yeah.
It's 30 years.
We go back
and I do want to, though, go and give the listeners a little bit of an insight just how amazing you are. And because it's fair enough to say that you've achieved, and for the UK, from an allergy perspective, you've done a lot. So at the moment, you're professor in pediatric allergy at King's College, and you've worked for many years as consultant pediatric allergist at the Evelina in London. But I think what is important to say that 9 years of those you will lead in the allergy services, if I've got that right.
Yeah, distant memory, but yeah.
Exactly. But you also started the King's College, so KCL Allergy Academy, which is still really educating and a major source of information for UK healthcare professionals. And you were the BSACI, so for those listeners who don't know, so British Society of Allergy and Clinical Immunology Chair from 2018 and 2020.
Yeah, I got the pandemic.
Exactly. You were that. But I think more recently, and also really exciting for us collaborating with you, that together with Professor Gideon Lack and George Dutoy, you've established the Allergy Center for Excellence in London's Harley Street medical district. And I will also put the link. I'll make sure that the link is there once we put this podcast out. And you've really been starting within the ACE clinic, lots of advanced diagnosis, and also we'll talk about oral immunotherapy or OIT that you're doing there. You've had lots of awards. The most exciting awards where I kind of feel I've contributed a little bit was the OBE that you received last year. So many of us had to write motivations. And I think we shouldn't ignore that you were included in the Tatler's Doctors list in 2013 to 2026 of the best
Showing my
UK
age, that's all.
Exactly. So as I said, the primary topic today is really oral immunotherapy or OIT. And I think I want to launch and to just say, what is OIT?
Great question. And you know, it causes so much confusion because it's one of those treatments that just has loads of different names. So when we talk about food desensitization or oral immunotherapy, technically OIT stands for oral induction of tolerance, but it's all the same thing. So this whole idea, and often families will often come in to say they're here for microdosing. That seems to be one of the terms that people have found. But again, all the same idea, which is that if you've got an allergy, we can give you small but gradually increasing amounts as a way of making you less sensitive to it. And if you're somebody who has got a peanut allergy, for example, and you react when you only have a quarter of a peanut, and we can somehow turn you into somebody who only reacts when you have 2 peanuts, then that's going to make a really material difference to the level of risk that you have when you eat out, because we know that whereas 15 years ago, every time I used to see patients with food allergies, they just tell me about all of their reactions over the last year. Now, thankfully, they're way less common because there's much better awareness, better understanding of it, food labelling's better. And as a consequence, the vast majority of reactions that happen are accidental reactions as a result of cross-contamination. Somebody used the wrong knife when they prepared your food. They didn't rinse out the pan. There was something left from the previous thing that was in there. Those sorts of exposures account for most of the severe reactions that we get, but they're relatively small exposures. So if you can just nudge somebody to the point that they're not that sensitive, then you're going to make them a lot safer and you're going to make their life a lot easier.
And we've got experience of lots of families that have been traveling that couldn't travel, for example. So you talked about this kind of confusion, and one of the questions that I often get is, so we've got OIT, but What about the milk ladder, for example, and the egg ladder? How does that differ from OIT?
Yeah, it's a great question. And historically, it was quite an easy answer. They were very, very distinct because when we first developed the milk ladder, and that was, we can claim credit for that, can't we? That was us developing the first milk
2013.
ladder very long time ago. And the idea was is that if you had a delayed type milk allergy, so there wasn't a risk of a nasty reaction, then at home you could gradually increase the amount of milk that you had in your diet to work out what you could get away with before you caused any symptoms. So it's sort of like a dose finding exercise to work out that you didn't have to be that restricted. And life is a lot easier if you can eat cakes and biscuits and stuff, and you only have to avoid plain milk. But you could do it at home very safely because the worst case scenario if you had too much milk is you'd get non-IgE mediated delayed type symptoms, upset tummies, things like that. That was fine, there's no risk of anaphylaxis. But it sort of morphed into something else, and people started seeing it as something that was firstly a useful tool for immediate type milk allergies. And of course, remember very well that we put in big bold letters across the top, this is not for immediate allergies, because we were nervous that if people just did this gradually increasing thing at home with immediate type allergies, usually they'd be okay, but occasionally they weren't. And we've all seen cases of anaphylaxis when they've been badly advised, not properly risk assessed, to just go and do that at home. But then it started turning into something else, which is rather than just a means of working out how restricted you need to be, it became a therapeutic tool. Actually, this is where it starts getting closer to what immunotherapy is. And now our practice with milk allergy and egg allergy is when it's diagnosed ideally nice and early. So you get to see the patient in the first few months of life, they've recently had their reaction. We'll very quickly aim to essentially put them on these ladders as a way of getting small but increasing amounts into their diet to make them less sensitive. So essentially, it is for some patients a form of desensitization. But it remains for those patients who have delayed allergies, for example, not that at all. It's just a tool to help limit the level of restriction that you have.
I think what is often very useful is because that's where we collaborate. I mean, OIT, of course, dietitians collaborate, but not as intensely as most probably with the ladders, because, once we rely on your service to say, this is safe, you can do it at home, and then we cautiously do it at home. So, you kind of gave a little bit of background. I suppose the question now is, to which foods can you do OIT, and is there a difference in success rate? So let's start with, to which foods can you do OIT?
Well, technically you can do it to anything, but with experience, you learn a lot about the value of desensitization to different things at different times, and really importantly, in different patients. And so this is a really, really personalized treatment. So you get a 15-year-old in who tells you that they're allergic to Brazil nut, and we'll have a conversation, and it would usually land on the fact that it's doable to avoid Brazil nut. Yes, you have to take sensible precautions and carry adrenaline just in case of a severe reaction, but it's not stopping you going away. It's not doing things. The correct way to treat that allergy is avoidance. But if you see a child who's, 13, 14, same age, but they've got a peanut and a sesame allergy, and because of that, it's really difficult socially. If they go with their friends to places like Five Guys, it's just impossible to be in there because of all the peanuts. They want to go travelling, they want to backpack around Thailand. I saw a kid in clinic this morning. They had clearly changed this child was changing his travel plans to avoid the places where he knew those allergens were going to be more of an issue. Then that's where it's really helpful to talk about treatments, because if you can turn that child into somebody who's much less sensitive, it's going to facilitate them doing all these things that they'd otherwise be too frightened to do and keep them a lot safer. But age is a really important part of this as well, because when you get younger children, what you can achieve with desensitization is way different. So traditionally, we've always seen desensitization as a way of making you a bit less sensitive so that you can be what we call bite safe. You can eat a couple of peanuts. So as long as you still tell everyone you're allergic and you have your emergency medication, you're safer than you were, but you're still allergic. It turns out, as we've learned more about these treatments, that if you do these earlier and earlier, and if you actually do them very close to diagnosis in infancy, actually you can get way more than just getting them to eat a couple of peanuts or a few sesame seeds or a couple of cashews. You can actually get them to the point that they're able to fully reintroduce that food back into their diet and live their life as though they're not allergic and not carry emergency medication. But that's almost completely contingent on them having, getting access to their immune systems when they're still what we call plastic enough, malleable enough to make those sorts of changes. And that basically means doing this as young as possible. So when I'm meeting a child for the first time that we're diagnosing with nut allergies in early childhood, I'm really keen to focus on those foods that if we don't treat, they're very unlikely to outgrow. And if they don't outgrow them, because if you're going to outgrow your nut allergy or sesame allergy, it's usually by the time you're sort of 4, 5, 6 years of age, it's going to be much harder to desensitize that child and we won't get the same outcomes. We'll be able to treat them, but not with the same effect, the same scale of effect that you can achieve when you do it when they're much younger. And that then puts us into a little bit of tension with the same small children who have got allergies to peanuts and sesame and tree nuts who are also allergic to milk and egg, which they commonly are. And that's where often the conversation is we don't really want to get too involved in complicated and difficult treatments for things that are probably going to get better on their own anyway. So great if you can do a home-based treatment, which for me, you really need to be getting in there early. So ideally before 1 and certainly before 2 to start doing these home milk and egg ladders. But if you've got a child that's 4 and has had quite a significant reaction to milk or egg and the numbers on the test suggest this may not be going away anytime soon, I'd still much rather treat that child's nut and sesame allergy because I'm going to have a bigger impact on them. There's a decent chance that if we do nothing with the milk and egg, it still might get better on its own. You know, we always go back, first principle of medicine's first do no harm. We don't want to do treatments for things that if you didn't do it, it's going to get better anyway. But there will come a point with many of these guys, if they're not going to outgrow their milk and egg allergy, it sort of becomes apparent. They're getting old, the tests are getting bigger, the reactions are often getting more significant, and it's becoming clear that just waiting isn't going to do the job, it's just going to stay put. Then we would start talking to them about more formal desensitization for milk and egg. But we do way less of that than we do desensitization for things like nuts, sesame, legumes, for example, peas, lentils, chickpeas, and even things like mustard and pine nuts. There's a whole raft of things. Where we do limited desensitization are things like fish and shellfish, because when you speak to people who've tried doing this, and you know, we've had a bit of a crack at this, it's really hard to get the kids to eat the food. They really don't like it. It's really hard with getting the foods that you can use at tiny doses, measuring doses, and often they're pretty stinky. And experience of those who have done a lot of this is that the kids generally don't keep up the regular exposure. They just don't want to eat it. And given that those foods are often relatively straightforward to avoid, those are things we do much less desensitization to. Although that said, I've got a group now of prawn shrimp desensitization kids that are all going pretty well off the back of a paper from Stanford that actually showed really good results. So I sort of revisited the conventional wisdom and I've sort of started that again, and actually so far so good. But a lot of this is really down to sort of those individual conversations about which allergies are bothering them the most. I get some families where they say, my child's got multiple nut allergies and sesame allergy, but we feel that we're sort of on it with a nut allergy. We can deal with it. Everybody knows what we're talking about. It's something that people understand, but sesame's really hard and that people don't get it. And it appears in places that make us really nervous, and there's hummus at every birthday party. And actually, if we could just not have to worry about the sesame so much, life would just be a lot easier. And so that person might be a really good candidate for desensitization of one thing, but not the other thing.
So Adam, before I launch into what the risks are, I think it would be interesting to know, because you offer at your services in the ACE clinic a desensitization program. What would a journey look like? Just take so that people that are listening to it, what does it mean to be desensitized? Yeah. Because I think there's often this misconception. I see somebody once and then I just kind of plod on at home. And I think it would be useful to tell what does a journey like that, let's say peanut or sesame, look like?
Yeah, well, it always starts with an initial conversation, which is ensuring I always say to my patients, there's 2 questions that we have to answer when it comes to thinking about desensitization. The first one is, could we do it? And what that really means is, are you medically suitable? Which essentially is 2 things. Are you definitely allergic? And we unlabel or delabel so many people who come to us saying, I really want to be desensitized, and they just turn out not to be allergic. They've been given a label based on a previous allergy with a positive skin test that, you know, the allergy's gone, they've not been seen for years, they were overdiagnosed in the first place. There's a lot of that. So it's incredibly important to get it right. So OIT got a little bit of a reputation in the US that because people weren't being quite as careful with diagnosis, they were desensitizing people who actually weren't allergic anymore. Now, of course, it goes fabulously well with no side effects and is 100% effective because you were never allergic in the first place. So we are, you know, my golden rule is no one is getting desensitized in this clinic unless I'm convinced they're allergic, and they're convinced that they're allergic. And you need to be sure of that before you start, because once you start, it's harder to work it out. Because if halfway through the treatment it's going well and you think, well, is it because I was never allergic in the first place? If you do a food challenge and pass, you don't know whether it's because of what you've been doing or you weren't ever allergic in the first place. So we're really big on this. So first question, could we do this? Are you allergic? And if you are you otherwise well enough to do this? So if you've got asthma, often they have, is it well enough controlled? And if it isn't, let's get it sorted out. Is your eczema well enough controlled? Is there, any other things, whatever it is, you have to be sort of in pretty tip-top form. And then if we've agreed you could do it, then the much more nuanced second question is, should we do it? And I always say to people, this is not the treatment of food allergy. This is a treatment option for food allergy. And it's right for some people and it's not right for other people. But for the right person at the right time, done safely in the right way, it can be transformational. But for the wrong person, it just creates absolute havoc and very miserable children. And we learned this very, very quickly. When we first, the sort of lever that led to our first opening our clinic was Palforzia getting its license in 2021. So it's like, trumpeted as this paradigm shift in allergy treatment. You're going to be able to get desensitization to peanut for children, because it had a license, age 4 to 17. And that meant that when you woke up on the day of your 18th birthday, you were no longer suitable for treatment, which of course is ridiculous, but chimed perfectly with the way paediatric services are set up that don't want to let anyone over 18 through the door. So what we inevitably got when we first sort of announced we're offering this treatment is a veritable army of 17-and-a-half-year-olds
my goodness, yes.
realised whose parents realised their children were going to potentially miss this boat that was going to, make this enormous difference to them. So they dragged a lot of these 17-year-olds kicking and screaming, saying, I've got my A levels, I really don't need to be doing this, and it's a lot of visits, and it's going to, and I don't want to do this. And it doesn't work if the patient isn't completely bought in and engaged and wants to do it. If it's their parents that want to do it, but they don't want to do it, don't bother. It's not going to go well. And you'll just have families that are fighting with each other every day over whether their dose should be given or not. The pathway is have a conversation. Shared decision making is our buzzword. And what that looks like is we have an initial meeting where we do the testing, we confirm that they're allergic, we give them a little bit of an introduction to what's involved. We'll often do their lung function to make sure that any asthma is well controlled. We often have to do a little bit of diagnostic work because they've often avoiding stuff they're not really allergic to, or sometimes they're not avoiding stuff they haven't realised they might also. But we need to get the full scope of it, because how many allergies you've got and which things you're allergic to are going to inform what decision you make about going forward. And then we always say, look, if you're still interested with this very preliminary conversation, I send them really detailed written information for them to have a good read of. And if they're interested, I'll send them additional sort of, published papers and things and other resources. And then we organise a follow-up call, which is often done with one of our specialist nurses, where it's got a slightly different sort of angle to the conversation. It's much more practically, what does this look like? How many visits and what time of day and what days of the week does the clinic run and how long you're going to be there and how do you do this when you're at home, etc. And only after they're happy with that and they've answered all their questions and they've always got my email so they can ask them anything, then we'll say, okay, we're doing this or not. So, for me, we've failed. If anyone shows up for that first day of treatment, they don't know exactly what they're getting themselves into. Because if they don't, it's not going to go well, because all sorts of things will come up where they'll say, but we didn't know that we had to do this and we didn't realise we had to come every 2 weeks. And anyway, then you can get started. So first day, big day, because there's a lot of training involved. So you'll show up. Now, the purpose of the visit is to start the first dose. And sometimes there's a series of small doses, but as often as not, it's a single first dose, where we'll give the dose under direct clinical supervision. They're kept there for at least an hour. But alongside it, there's a lot of training about what they need to be looking for in case of an allergic reaction when they're doing the dosing at home, the times when they shouldn't be giving the dose. We have a lot of what we call golden rules about dosing, because that keeps these kids a lot safer, because they're much more likely to have a reaction to a subsequent dose if they're not well, exhausted, under the weather, any number of things. So we train
the same rules for the ladder.
Exactly, yeah. And alongside that, we have to, we're very, very keen, this has to be done in a very supportive way. So they have an email address that they can contact. They have a 24/7 phone number that they can ring and get a senior clinician if they've any queries. We want people to feel that they're well supported. And the truth is that, and certainly my approach to this is, whenever we get queries, I'll always say, well, what do you think you should do? It's the way I was trained as a doctor, because they don't want to be phoning you in 7 years' time every time their child has got a runny nose. We're basically training them to sort of understand the principles behind treatment, and most of them get it really, really quickly.
And I see that with the ladder as well. So the first step, normally you get lots and lots of emails with photos of spots and things like that. Then they kind of come down.
And we're bringing in there's going to be an app which we've sort of got colleagues in the US have been using for some time. It's been developed through an immunotherapy clinic, but that doesn't replace the fact that sometimes people just want to ask, and they want a personal email, and that's absolutely fine. That's always going to be the case.
It is really stressful to
It is,
give
and for
your child something that you've been told
some
to
of these
avoid.
families, it's such a big leap because they've absolutely ingrained in themselves and their child, whatever you do, don't eat this food, and then it's so come along, we're going to
No,
give you the food and
but
eat it. Yeah.
I think what you've really showed outside of the shared decision making, which is, I believe, absolutely that's the core of modern medicine, how we should be practicing. I think it's this reassurance of doing it under supervision. You're not alone
Yeah,
in
that's
this
really
journey.
important.
And I
And
wanted,
yeah, I was going to say, we also, at the start of this, we also get the families often together on a group session with one of our psychologists, because the mindset is so important. If you go into it nervous, anxious, feeling like you don't know what you're getting into, it's much less likely to go well than if you go into it really positively, expecting, which you should, expecting to get through it, because the overwhelming majority of people do. It just makes the whole thing much easier.
and if I may add, you said, there are certain conditions of where you're kind of going, maybe that's not the right thing. You talked about asthma's not well controlled. You often refer to me children that have very severe food refusal and aversive eating patterns.
Yeah.
Where I say to the parent, look, the anxiety is up there for any new food. It's really not worth it. So you can understand the parental pressure, but actually, whilst you might achieve immunological tolerance, it might do harm from a psychological perspective because they're so stressed out.
Yeah.
So I wanted to touch just on risks because, I can see you try to keep the risks down, but are there any risks?
Of course, everything, no pain, no gain, sadly. It is, I think the easiest way of explaining it is this is a vaccination in the sort of, truest form. You are using the thing that causes the problem as a way of making you less sensitive to it, to keep you safer in the long term. And like all vaccinations, there's a small risk of running into trouble at the beginning. So I usually say 3 things I raise with patients before they go through this at the beginning of all of this. Number 1, actually the number 1 reason that people drop out of treatment, logistics. Simple as that. It's a palaver. You've got to come and see us every 2 weeks. You've got to do the dosing at home every day. You've got to avoid exercise for a period before and afterwards. All of these things mean that you've got to be really committed to want to do this. And we've looked, so in our under 5s, for example, we know that our completion rate is 95%. But if you look at the 5% that don't complete it, the number 1 reason is logistics. And that'll be things like the child just refuses to eat. In the older kids, logistics is usually the child just doesn't want to do it. And, they're too focused on other things in their life. They're just not motivated and you can't make them do it. And that's fine, nor should you. So the next thing I always mention is it's sort of the obvious thing. They're allergic to this thing and we're giving it to them all the time. So there is a chance of allergic reactions. And whilst most allergic reactions are minor and most people don't get them, occasionally you can have really nasty allergic reactions. Now, what we mean by that is anaphylaxis, and that's often less dramatic than people are imagining. What it really looks like is they have their dose usually at home. So although you're much more likely to have a reaction when you increase the dose, which is why we do that under supervision, you're 5 times more likely to have a reaction when you increase the dose. But for every dose you do under supervision, you're doing a dose at home every day for 2 weeks. So you're having 14 times as many doses at home. So overall, you are more likely to have your reaction at home. And you're more likely to have your reaction when you're more sensitive, and that will be because you're different somehow. You're unwell, you're overly tired, you've got an infection on board. So then, hence we have all of these rules that massively mitigate this risk of saying don't give a dose when you've got a temperature, you're under the weather, you're really tired. And that works really, really well. And the overwhelming majority of significant reactions that do happen, the parent is immediately able to say it happened because of this rule, which we didn't quite stick to. So that's great. It doesn't mean they're going to stop treatment. They know what not to do next time, and things usually go much better afterwards. But what those reactions would normally look like are mild anaphylaxis, which essentially means a reaction that involves usually a persistent cough, for example, afterwards. But the right way to treat that, to make sure it doesn't go any further south, is with adrenaline. And the overwhelming majority of those sorts of reactions will respond to a single dose of adrenaline. And thankfully, our experience has been much more broadly than this, that it's been incredibly unusual we've ever needed, for example, second adrenaline, and we've certainly never needed any additional care of any sort, intensive care, for example, for any of our patients. And that's been a broadly global experience.
So what I come across a lot of times is these very mild gastrointestinal symptoms.
Yeah, so that's the third one I always talk to people about, the tummy stuff. Now, But the headline grabber is something called eosinophilic esophagitis. So that's an inflammatory condition of your eating tube, your esophagus, also known as asthma of the esophagus, where you get inflammation in there that will lead to tummy pains, heartburn, reflux, and difficulty in swallowing. And that's the big one. And the worry with eosinophilic esophagitis is that the inflammation in that tube means that the tube narrows, makes it harder to swallow. There's a risk that things will get stuck, which is deeply unpleasant for somebody when they have that. But also, if that's happening on an ongoing basis, that actually it sort of tightens up that tube, and you actually end up having to somebody has to go down there and sort of force it open in order to allow you to eat properly. So it's something that needs picking up very, very early in order to ensure that it doesn't cause too much trouble. Now we know, and this is where it can get a little confusing, we know kids with food allergies are prone to this condition, regardless of desensitization. So we know the prevalence is sort of 1 or 2% amongst food allergic kids. We've known that for some years. It's a relatively new disease. It's better recognised now, but we know that allergic kids are at risk. So you're, of course, going to have a higher prevalence compared to the background population when you desensitise kids, because you're only desensitising allergic kids. And actually, the prevalence of eosinophilic esophagitis amongst kids who are desensitised is only slightly, it's broadly in line with the expected percentage in the population. But that's an expected percentage over a long period of time, and this is while you're desensitising that you see it. So our understanding is that doing the desensitisation in those who are prone to get this problem, you're likely to bring it out. Now, for most of them, the symptoms are often mild, and whereas previously we'd have said, right, that's it, we're stopping, we're not doing this, it's not worth the risk, and you'll just see it settle down. In fact, we've got braver over time, and we now know that usually you can just reduce the frequency of the dosing, reduce the dose for a little bit, basically go what we often describe as low and slow. You just drag the process out a little bit longer. The symptoms will settle down and you can get past them, gradually increase those without them returning. Sometimes we might use a little bit of medicine alongside it and actually get past it, and then they go on and they successfully desensitize without a problem. But there are a small number where you just don't their esophaguses are determined to stay inflamed. And the only way that things settle down is by stopping, backing off. And with, occasionally they will still need further treatment. Usually things will settle down once you stop. But it's interesting, actually, my experience has been is that for, again, we probably about 1% of our patients will get this trouble. You'll often find that there's a bit of a background, a bit previous in the story. And what I mean by that is parents, first, secondary relatives who've got eosinophilic esophagitis. So, we often ask about that before you start, although it doesn't change whether you do it or not. I don't think anybody's going to not do it because there's this notional small increase in what is already a very small risk because of a family relationship. But it does mean that you need to keep a close eye on these things.
And I've often found that there might be a history of mild non-IgE in early infancy and so on.
Yeah, so early refluxy stuff,
exactly,
and probably early signs that this was always going to be a kid who was going to have this problem.
That there was a risk. Adam, we're coming kind of to the end of our discussion, but we've spoken about what it is, what type of foods, the risks. I suppose, my question is there anything that I've left out that you feel through your experience from the clinic that should be shared that is not that common knowledge around OIT that we've not touched on during our discussion?
I would just say, for me, the important thing is I don't think OIT is for everybody, but I think it is important for anybody whose child's got food allergy or has food allergy themselves that they know what their options are. And then they can make an informed decision. And of course, we now have more than OIT. We have biologics, so these injectable medicines that make you much less sensitive. We've got sublingual immunotherapy, which used to just be for pollens and dust mite, but now we're doing it. We're starting to do it for food. We're in clinical trials, but very late stage clinical trials for patch immunotherapy. There's other injectable medicines and in fact oral medications coming out. There's so much going on in this space. And I got a sort of quick reminder this morning when I saw a patient I hadn't seen for about 7 or 8 years. And they were coming and expecting me to sort of, repeat the skin test and say, oh, you're still allergic. And we ended up having this completely different conversation about all these different treatment options. And they were absolutely amazed. It's, I can't believe, why did I not know about any of this? And it is remarkable. You can be food allergic and just because you have so few touch points, unfortunately through the NHS, for example, that make you aware of all these emerging options that you can remain blissfully unaware. And I think it's, really important for people to feel that they had the option and they had the choice and they had the awareness. And that's fine if they decide it's not for them. But I think to not know and then find out later, we get a lot of very upset parents who sort of come along and they say, had we have known, we would have done this. many years earlier, and I have to sort of squirm in my chair thinking, had we have done this many years earlier, the outcome would have been better, it would have been much easier, there'd have been less side effects, it would have been, all of that, but that doesn't help the conversation. But I think we've got a very big piece to do on awareness here, so that people understand that they do have options.
And I think that's a nice message to end off. I think the first thing you've made very clear is don't do this without having somebody that actually knows their way around MIT. I think that's the very first message. I think the other thing is also to give any listeners hope. It's constantly changing, and maybe also those who have not seen their allergist in a long time, to say go back, because it is every year we learn something new, and there is something new that has changed. So it might be something from even last year, it might have changed.
Yeah. We've got this funny situation where sometimes it's quite intuitive to say, well, let's just wait and see how things go over the next few years, and then we'll see whether we need to intervene. But unfortunately, all these interventions work much better if you do them early, and so waiting isn't necessarily a great strategy if you're planning on being interventional.
Exactly, and we use the word active in allergy terms, active introduction, and all of those so much more. And it's literally like that. It is an initiation early and actively.
Yeah, absolutely.
For all of the listeners, we'll make sure, Adam, that we have your link also for not your personal details, but your clinic's details.
Yeah, not my mobile.
Absolutely not your mobile, but it's. I think for me, it's been so informative, and hopefully for the listeners as well. Thank you so much for making the time.
Pleasure. Lovely to be on it.
Thank you for listening or watching this week's podcast. You can follow me on various social media platforms, which we'll share on the screen, or you can visit my website at roseannepediatricdietitian.com. You can also like this podcast on our Step by Step Kids Nutrition YouTube channel. Thank you very much.